All right, our last talk of the morning is on advanced cardiac support in the ICU by Dr. Dudzinski, who is a cardiologist here at MGH and has also done additional training in critical care. Dr. Dudzinski?
Thank you so much, Dr. Frank, and to your co-organizers for inviting me. I've attended the first 3 days of the course along with the audience. It's been wonderful, and I'm very glad to participate here. As you mentioned, I'm a critical care doctor, but I'm a cardiologist, not a pulmonologist. And so I'd like to expand on some of the themes we heard from Dr. Rubin and talk about cardiac support and improving our skill set and algorithm in the ICU. So we're going to revisit shock. Dr. Rubin touched on this a little bit. The bulk of our talk will be on mechanical circulatory support of various stripes. And what I want to provide to you as an intensivist or a pulmonologist is really a heuristic, a toolkit that you can evaluate options so you can apply these to the physiology in front of you and to your own hospital system. So most people think of shock really as hypotension, and this is obviously incorrect and crude because there are many types of normotensive occult cardiogenic shock. And our job, whether we're in the unit or seeing consults on the floor or receiving patients from other hospitals, emergency room, is to think, does this constellation constitute incipient or comorbid cardiac dysfunction? And so these are vignettes that I've seen and you've seen over the years, but we really want to have a very holistic and broad overview of shock, recognizing that it's pathology that goes from the ion channel level all the way up to the organ and system dysfunction. So it has cellular, metabolic, and complete circulatory features. And every organ system is indicated in this diagram is affected, and not just hypotension, but evidence of congestion, which can affect visceral organs, malperfusion, which can affect other organs and systems, capillary refill, mental status, and whatnot. So we want to have this very broad lens to think, is this patient's constellation indicative of circulatory compromise? And so the phenotype of shock with which this audience is very well acquainted include distributive and hypovolemic, where there are insults to SVR or insults to preload or volume status. What I want to focus on for today is the cardiogenic phenotype. Again, Dr. Rubin talked a little bit about this. The primary derangement here is that our cardiac output is insufficient. And so let's think about that in a contemporary lens. This is from a multi-center network looking at cardiac ICUs, and it's showing that cardiogenic shock, not surprisingly, is the most common there, though we still have to think about other modalities of shock in 1/3 of our patients. So again, as an intensivist, we want to have this very measured and holistic overview to think about what are the patient's derangements, what is the status, does it indicate shock, and what is the etiology. Cardiogenic shock is a lethal diagnosis. Mortality, this is a case fatality rate graph, has gone down somewhat over decades, but still remains about 30 to 40%. So this is something it is imperative that we recognize it early, and act early. And these are other more contemporary graphs showing and stratifying by extent of other organ dysfunction. So no other organ dysfunction, multi-organ dysfunction, but you still see that the in-hospital mortality is 1 in 3 or 2 out of 5. And that's really been a call to action for our field. We need to phenotype better cardiogenic shock as we think about approaching a patient. And we can do that by assessing whether there's left ventricular dysfunction, right ventricular dysfunction, or both. So we're going to have an impaired cardiac index in all of these states, and our job is to try to parse that out at the bedside. We can do this, of course, with invasive hemodynamics. We can also do it in part with examination findings. And the basic strata here are left ventricular dysfunction will be indicated by an elevated LV filling pressure. So when the ventricle is dysfunctional, it can be impaired, and it will require a higher pressure to work to generate the same stroke volume. So left ventricular failure typically has a higher wedge pressure. Same thing will be a left atrial pressure, or a PA diastolic pressure will be a crude assessment of that. Right ventricular congestion will be heralded by elevations in the CVP, the central venous pressure, meaning that that right ventricle needs to operate at a higher pressure. And of course, there's a universe of patients who have congestion and dysfunction of both ventricles. So we need to be mindful of the differential diagnosis, and Dr. Rubin showed us some of this. For cardiologists and for patients, you may see acute myocardial infarction-related cardiogenic shock, which is primarily left ventricular dysfunction, is the most common modality and type of shock we'll see. That can lead to other types of dysfunction secondary to the MI. There is a large universe of heart failure and cardiomyopathic-related syndromes, but really every tissue system in the heart can be dysfunctional. Valves, acute MR, acute AI, as we heard from the last lecture, left ventricular outflow obstruction, which you can see in any patients, especially with distributive or septic shock, who have a very vigorous contraction at the left ventricle base, which actually inhibits flow from the ventricle to the aorta. Obstructive shock syndromes like tamponade, pneumothorax, PE, pericardium can be dysfunctional, and even arrhythmias can lead to cardiogenic shock. An important contemporary framework to grade cardiogenic shock is called the SCI classification. SCI stands for Society of Cardiovascular Angiography and Interventions. And this pyramid is just a risk stratification that helps us phenotype our cardiogenic shock patients from at risk to initial indicia of hypoperfusion to overt hypotension. And then stage D is when your initial interventions are not working, and E is a patient in extremis. So I have colored on the side, hypotension, hypoperfusion, not responding, and pre-arrest to help me remember all the data in that big triangle. This is important prognostically because as the admission SCI shock stage increases, mortality increases as well. And this has been shown in at least a dozen contemporary cohorts. What's also important, what I really like to emphasize to our residents and fellows, is the value of iterative, repeated assessments. And that really goes for everything in medicine, especially in an ICU environment. And this was shown with data, and actually just a recent paper that an MGH co-author was on, first author, about dynamic staging. So the patient's initial trajectory, do they start at what class and what class do they move to, has prognostic impact. So if you move up class, you have a worse impact than if you didn't move up the class. So what can we do about cardiogenic shock? Well, for our patients who have suffered an acute myocardial infarction, the mainstay of treatment is coronary revascularization. You'll note the date of this trial, 1999, it was published, recruiting patients in the mid-1990s, 302 patients only, and they were randomized to revascularization or not. This outcome was not significant until it got to 180 days. And this, despite being 30 years old, remains the mainstay of our intervention in acute myocardial infarction-related left ventricular predominant cardiogenic shock. Subsequent data has tried to evaluate, well, okay, we have this sick patient, and we know they had their STEMI because of, say, a particular lesion, but they have disease everywhere. Should we take care of everything? And that's an interesting hypothesis, because in other acute coronary syndrome cohorts, in patients who are not in shock, there's a growing body of data that complete revascularization, taking care of every significant coronary stenosis, improves outcome, reduces major adverse cardiovascular events, and reduces future stenting needs. However, our cardiogenic shock patients are different. When you have that patient in cardiogenic shock, and they are spending more time in the cath lab, getting more contrast, there is actually harm. And so it increases mortality, renal dysfunction. And so for cardiogenic shock patients, we do the culprit vessel only, the one that caused the STEMI, and then we stop the procedure and bring them to the cath lab, bring them to the ICU. So besides revascularization, what are the other levers which we can adjust hemodynamically in our patients? And there really conceptually are very few. We can optimize the volume status. In some patients, volume status is insufficient, like hypovolemic shock. In our cardiogenic shock patients, typically the volume status is exuberant and it needs to be reduced. We can use inotropes to improve native contractility. Of course, they're going to come at a cost of increasing myocardial oxygen demand. We can also try to modulate SVR. In many cardiac conditions, we would like to reduce systemic vascular resistance and some pulmonary vascular resistance to help the ventricles eject. Unfortunately, due to systemic ambient hypotension, we can't do that. And then lastly, what we'll get to is mechanical support. So I put this diagram up not to go through it, but just to remind us and for you to have in your slide set, the whole universe of vasoactive options, which roughly include vasoconstrictors, which find very limited use in cardiogenic shock, and then various types of inotropes, which generally come in two flavors, dilators and constrictors. And so we have some interesting clinical trial data that's worth reviewing. The SOAP-2 trial is well known to members of this audience. There was about 1 in 6 patients in SOAP-2 that were a cardiogenic shock phenotype. And when dopamine versus norepinephrine were compared as sort of a vasoactive agent in those patients, dopamine led to increased mortality in those patients. So we do not use dopamine in cardiogenic shock based on data that is 15 years old and still stands. A trial I'd like to call your attention to is from a few years ago. It's called Capital Do Re Mi. It was run in Canada, and it was assessing the difference between two commonly used inodilators, dobutamine and milrinone. These act via different mechanisms. Dobutamine is a beta agonist. Milrinone is a phosphodiesterase inhibitor. And these are commonly debated, which one is useful, which one is less harmful. And so the Canadian group made a very large composite outcome, as you can see: death, arrest, escalation, MI, stroke, renal replacement therapy. So with this large composite outcome and relatively few patients, now again, they were sick patients. You can see most had severe LV dysfunction, 80% started in SCAI stage C, but there was no difference seen from this trial in between the inotropes and this composite outcome. So I have my patient in the ICU, or I'm seeing them in the emergency room, or receiving them. I'm going through this checklist in my mind: fluid status, vasoactives. I'm trying to minimize complications, like I'm building my regimen. But then I'm have this fear in the back of my head: what if my strategy doesn't work? What is my bailout? And so I emphasize to all of our residents and fellows: as soon as you see the patient with cardiogenic shock, suspected or ongoing, we're going to think of our backup and bailout strategies, which increasingly over the last decade or two are mechanical options rather than pharmacologic. So I want to emphasize there is a time urgency in cardiogenic shock. When the patient presents, it is a hemodynamic problem, and it is amenable to hemodynamic interventions. Once cardiogenic shock has been persistent for a certain amount of time, organs are becoming malperfused, they are congested due to visceral congestion, and they're ischemic and having metabolic derangements. And so at some time when we switch along this time axis from blue to red, we're losing the ability for our hemodynamic interventions to have a beneficial impact. This emphasizes the time importance at recognizing cardiogenic shock and deploying modalities. So I'm going to get to the toolkit and the heuristic. How would I think about mechanical support? So if we had to design, if we had to design an ideal mechanical circulatory support, we'd want it to be able to be placed rapidly, peripherally, so not needing like in a laboratory or an operating room. We want it to be able to be readily available, easy to exchange, remove. We want to minimize complications, especially bleeding. Cardiology literature over the last decade is really rife with the theme that bleeding is bad. We use certain medications to get an ischemic benefit, but anything that causes bleeding is bad. We want the patients to be optimized. We want them to be able to eat, respire on their own, and have physical therapy. And so these are some of the constraints that will govern our thinking. Now, because there are such rapid evolution in this field and variance in practice, this is just a snapshot to show that among contemporary ICUs, the use and the intensity of use varies wildly. So there are many practice variations and many different ways to go about this. But what I want to focus on for a few minutes is this sort of checkbox. They call it in the paper hemodynamic equation. This was written by one of our colleagues at Tufts, who's a national leader in this area. But I think for this audience, we can kind of think about it as GDMT for the heart. There are certain goals we want to assess, and we want to think about how modality might apply to my patient so we can pick the right modality. And so the axes on which we will define an MCS strategy include: are we supporting the blood pressure, and are we perfusing the organ? So that's goal number one. Number two, what is the strategy doing to the ventricle? Is the ventricle being subjected to more work, or is the ventricle being helped, allowed to recover and rest to maybe recuperate on its own without need for transplant or durable support? Coronary perfusion is important, really for the case of AMI cardiogenic shock. And again, because that's a vast majority of our cardiogenic shock patients, that's important. But just to note and say up front that in our etiologies that are not myocardial ischemia based, this will have less importance. And then the fourth parameter is assessing what's going on with the visceral organs. So I mentioned that cardiogenic shock will lead to malperfused and congested organs. We want to understand what our mechanical device is doing with that. So first, we could think about, as an entree to this, what if we use just medications? What if we use a pharmacologic strategy where we're using inotropes to increase cardiac output, using vasopressors to maintain the systemic blood pressure? So that's great. We can titrate the norepinephrine until we get the MAP goal we want. But what are we doing to the ventricle? Well, we are making it work a lot harder. And so in the case of a patient who just suffered an acute myocardial infarction, that's a little bit paradigmatically against what we're trying to do. So these medications, inotropes, have never shown mortality benefit because we are using a short-term bridge to maintain systemic perfusion, but it's costing us long-term myocardial recovery potential. Let's look at the grandfather of MCS. This is called the intra-aortic balloon pump. It was actually partly developed at MGH in the 60s and 70s. And what it is, it's literally a balloon and it's inserted percutaneously, typically via the femoral artery, but can be inserted via the axillary artery. Balloon sits in the descending thoracic aorta. The balloon actually inflates in diastole. And why in diastole? Well, if we inflate it in systole, we would actually be increasing the afterload for the left ventricle to eject again. So we don't want to do that. In fact, by deflating in systole, we actually reduce afterload for the ventricle, which is a great outcome. And we're actually helping by suction to remove blood from the ventricle cavity to the aorta for perfusion. So we deflate in systole and we inflate in diastole. And the inflation in diastole also has a benefit because when we increase the diastolic aortic pressure, we're actually increasing the perfusion pressure head on the coronaries. So especially in AMI cardiogenic shock, we can increase perfusion. So it provides a little bit of left ventricular support. Again, this is univentricular. This will have very little impact on a right ventricular state. Doesn't really do much for this central venous system. And it really doesn't provide output. If you look in a textbook, it's going to say, oh, the balloon pump provides a half a liter of cardiac output. It really doesn't provide any. It just facilitates the ejection of the heart. So again, this device was developed in the 60s. A seminal trial occurred in the 2012 New England Journal. They studied the balloon pump in AMI cardiogenic shock. And long story short, it had no short-term and longer-term benefit on mortality in AMI cardiogenic shock, and it went from a class 2 and was downgraded in serial guidelines. So now we need other strategies. And we really want to think about the flow for our patient. So I just think crudely about the different demographics of patients we may see based on their body surface area and gender. I want to provide a certain cardiac index. So if I just do simple multiplication, I get a rough assessment of how much cardiac output I'm going to need to provide mechanically. And then I can match that up to several different types of mechanical options that we're going to go through now. So let's just take a second and go through what is VA ECMO. So this stands for veno-arterial extracorporeal membrane oxygenation. So you can see we're going to have a venous and an arterial limb. We have a pump, and this is the out-of-body extracorporeal circuit that's going to both oxygenate the blood as well as provide carbon dioxide clearance. Now, how does this work? So from a peripheral cannulation of the vein and the artery in the femoral position, you have a cannula that reaches the central venous system. And this will drain blood and bring it to the pump. After oxygenation and carbon dioxide clearance, it's inserted peripherally into the femoral artery. So this is going to have a very interesting impact on physiology. This is a non-native direction of blood flow. But ECMO actually provides for us immense circulatory support, can provide 5 liters per minute, and will directly support arterial blood pressure. But let's think about, from the point of view of the ventricle, what's happening. So as I mentioned, the blood is returning via the femoral artery to the descending aorta, coming up the arch, and then it's actually going retrograde to the heart. So the heart is actually now facing higher afterload, just like if the balloon pump were to inflate in systole. What does that do? So as we increase ECMO flow, so these are pressure volume loops, and each bounded sort of quadrilateral is representation of LV work, and the width of this pressure volume loop is the stroke volume. So before we initiate ECMO, we have a certain stroke volume. As we increase the ECMO support, we're putting more pressure on the LV's ability to eject, and in fact, it will eject less. The EF will go down. The heart will be under more stress. It will eject less per beat, which is why this quadrilateral is shrinking. What does this mean? Well, the ventricle is going to operate at a higher end diastolic volume, so it's going to be dilating, which causes wall stress. The reduced stroke volume has some interesting implications for stasis in the heart. And then, sort of like a calculus thing, if we multiply pressure and volume, we actually get units of joules. So the area of this is LV work. And if we just had a patient with AMI myocardial infarction, we want to minimize work as much as possible. We want that left ventricle to not be distended. We want it to be decompressed and relax, so it is recovering. So that's an adverse outcome of ECMO. And here's an implication of the stasis. So if we're perfusing the aorta in a retrograde fashion, we're not allowing the aortic valve to open and eject, We can actually have stasis in the proximal aorta. These are examples of clots in the proximal aorta on patients on ECMO. And then we can work that all the way backwards. There could be stasis in the left ventricular outflow tract, the left ventricular cavity, right at the mitral valve and into the left atrium, and even back into the pulmonary artery. So it's very important that if we're going to consider ECMO on somebody, we have to think about their left ventricle and the ability to handle this pressure load that's imposed, and then what will happen to their heart and how do we address this, which we'll come back to. So like everything in medicine, we have to be very sensitive to the potential benefits we're going to get versus the actual complications. And ECMO, while it can be life-saving, does engender several dimensions of complication. Among those to be aware of are vascular issues, limb perfusion in particular. There can be malperfusion of the artery, the leg, downstream of where the cannula returns. Neurovascular complications, infection is common, which will come up as we think about should we use this in other shock states, and then various bleeding complications and renal failure. So if I keep going along this heuristic and I grade ECMO, so it's not supporting the ventricle, and actually, if we think about it from a coronary perfusion point of view, coronary perfusion is dictated by the diastolic blood pressure, but versus the pressure inside the heart. So if I make the heart distend, and I'm increasing that pressure in the cavity, there's going to be much less of a pressure gradient for the blood to go down. And so the coronary perfusion pressure will decrease. So it's not really good to rest the heart. Now, where we'll get a little bit of a benefit of ECMO is because we're directly draining the vena cava system. If the patient had a very high CVP that was congesting the liver and the kidney, we'll directly be draining that. So does it work? This was a recent trial. This sick AMI cardiogenic shock patients, and they added on ECMO to standard of care. And you can see the patients were very sick. They were all revascularized, but the curves are more or less superimposable by the end of the trial. And so we have to really think, why doesn't this work? And I really believe it comes back to this pressure volume problem. We are not helping. We are actually actively hurting the LV in the situation of ECMO. So is there a device that could make the stroke volume or the LV diastolic volume lower, and so we decrease the work that the LV is doing, where the device is doing the work and unloading the LV. And so enter percutaneous therapies. So this is a transaortic microaxial flow pump. These pumps sit across the aortic valve. From their inlet, they bring blood from the LV cavity, and then after a motor, they bring it and deposit it in the aorta. This device is inserted typically in the femoral artery, but also the axillary artery, depending on the configuration and the size of the device. There's various flow levels available. So this device will provide direct circulatory support. And again, depending on the device size you choose, can give up to 5.5 liters per minute. Let's look at what happens to the ventricle. Because we have a catheter in the LV apex, we are directly taking blood right from that. So the LV will not only not distend, it will actually get smaller. And notice this is more of a triangle than a quadrilateral in the other view. This is because of continuous suction from the LV, the chamber is never at equilibrium. It's always being drained. And so we are actually decreasing volume, decreasing work. This is a way to rest or unload or help the ventricle recover. Now, of course, the Impella doesn't really provide perfusion, doesn't directly impact the central system. So what I want to spend a few minutes on now is a very seminal trial that was just presented last year at the American College of Cardiology and simultaneously published in New England Journal. It's called DanGer. It's called DanGer because it started in Denmark, Danish shock trial, and then to recruit more people, it expanded to Germany, but it's a great name otherwise. They looked at AMI cardiogenic shock patients with low EF. They specifically excluded patients who had a hospital arrest. They excluded patients who would have any contraindication to the percutaneous transaortic device, and that mainly includes aortic valve pathologies or aortic pathologies. These patients were quite sick. You can see the SCAI classes. They were all at least stage C, lactate of 4, a high rate of vasoactive use and mechanical ventilation. All the patients got revascularized in both arms. Basically, the trial showed that most of the patients got Impella, a few crossovers, and then there was a few other crossovers to ECMO as a bailout strategy. The top line result, the curves actually diverge, and this was quite surprising at ACC 2024. They actually showed that the axial flow pump added to standard of care AMI cardiogenic shock improved mortality at 180 days, the number needed to treat of 8. What you also notice is that these curves, they get farther and farther apart over time. So is this proof of that hypothesis that we've saved the LV a little bit and we're seeing that benefit later? Maybe. Now, the numbers are actually a little small. And so the fragility index, which is basically how many patients we would need to change their endpoint to have the trial not be significant, was just 4. So it's not 1, but it's still pretty fragile from a clinical trial result. And then we have to juxtapose that with the number needed to harm. So with this device, similar to ECMO, there's bleeding, hemolysis, there's a need for renal replacement therapy, which in part is due to pigment, and the number needed to harm was 6. Now that's lower than the number needed to treat. Of course, that would imply that death and AKI have the same weight, and they don't. So we have to balance that for our patients. But we have to contextualize this trial even more. These are all trials, and actually we've seen all of these today, that had lower standard of care arm mortalities than Danger did. So it's unclear why Danger had a higher baseline mortality, but of course that would make it easier for them to show a difference. And people have questioned, is that why the result is significant? And if we look under the hood some more, there's actually some interesting stories. So the result was significant in Denmark, but not in Germany. And there was also recruitment in the UK, and it was not significant there. Unknown why. We have to really remember this is a very select patient. They exclude cardiac arrest. And so if we assess this theme about mechanical support that loads the heart, like ECMO, or unloads the heart, like the transaortic percutaneous device, we get to see some themes that emerge from an analysis. So ECMO does not have a significant improvement. Actually, overall, the percutaneous transaortic device may not have a significant improvement unless we exclude, just like Danger did, all the possible arrest patients. And then we see an important signal that it improves therapy. So then you say to me, well, what if I need the flow from ECMO? What can I do? Well, maybe you could combine modalities. So could we get the benefit of Impella along with the benefit in the high flow of ECMO? Yes, this is actually an area of investigation. And so if we combine ECMO with, for example, the percutaneous transaortic device, and we do it early, we actually see lower mortality rates because we're probably helping that ventricle. There are RCTs in this area. Now, you have to pay a price for this. Now you have 2 devices. So you have 2 loci of vascular complications. You have synergistic increase in bleeding and in renal failure. So we really need to evaluate this hypothesis going forward. So here's my summary for this. When would you need peripheral VA ECMO? When it's a true emergency, because you can do that at the bedside. You can cannulate with ultrasound. The percutaneous device requires fluoroscopy. ECMO can provide support to both ventricles and respiratory support. So this audience will know many different pathologies that would potentially need both modalities. You can't get that from just an LV support device only. So when would you use that? Well, if I'm seeing the patient, LV predominant shock, and if I think the LV might recover, like it may recover after certain MIs, maybe the percutaneous strategy is better because we're helping the LV limp along through the acute state. That's not true for everything. Maybe there's acute on chronic heart failures, all those other physiologic states and entities, it may not work. So this is the discussion you would need to have. So with these tools, how do you implement this? Well, one, in your hospital, you need a team to be able to deploy these. You also need a network. So are you a receiving hospital or are you a transferring hospital? So it's important to interface and link up with the other hospital in that link to have protocols for escalation, obviously diagnosis and recognition, and transport. And then another theme throughout medicine is that volume matters. There's a volume and quality relationship in most everything we do. So it's very important to become expert at a certain device or protocol and implement that expertise. So we're just going to switch a little bit of a theme. We were talking about LV shock, just going to look at RV shock. Dr. Rubin mentioned pulmonary embolism a few times. I think pulmonary embolism is a great topic for all us to think about. I know you have lectures from Drs. Witkin and Rodriguez Lopez coming up. So PE, this is a nice study from France reanimation registry. So very common cause of out-of-hospital cardiac arrest, especially in patients who had both initial non-shockable rhythm, history of VT, obviously, and then were young. 4 out of 9 cases were due to PE if those were all true. The treatment of PE, I'm sure Dr. Witkin will go over. We're just going to look at it quickly. This is a sky-like pyramid. And if we're going to focus on the highest risk PE patients who have incipient RV dysfunction from cardiogenic shock, we need to combine PE therapies, which Dr. Witkin will talk about, plus mechanical support. What we're trying to do is unload the pulmonary artery, but also protect the left ventricle and systemic perfusion while we are mobilizing PE therapies. So our menu of possible therapies just to support the RV are slightly different. So we have a right-sided percutaneous microaxial flow pump that instead of transaortic is transpulmonic. We can deploy various RVADs in various configurations, and we can also return to VA ECMO. Now, there's a very sparse evidence base for all of these in PE. It's actually, this is a slide I just put in this morning. This was a trial we participated in several years ago. It's called Recover Right. They used the right-sided transaortic pump and a single-arm trial, very small, proof of principle. They used it in RV failure after left ventricular assist device surgery or after left ventricular failure from MI. And they showed, again, proof of principle that this right-sided device increased cardiac output, actually about doubled it, and reduced CVP as we would expect as treatment goals for RV predominant shock. So this is where it can find some use, again, off-label or not so much guideline-based. But what about in PE? So now we have in PE, we have a dilated right heart. We potentially have clots in transit or clots in the vena cava, the right atrium, and the right heart. So we have to navigate this device through these dilated right-sided chambers. They could potentially entrain clot, and they could embolize it. And they could actually, if we put it in the wrong PA branch, could actually increase PVR, which we definitely don't want to do. These devices are really not able to be placed under echocardiographic guidance, but need to be placed with TEE and fluoroscopy. So again, if you have a crashing patient from PE who has PE-related cardiac arrest, you're not going to be able to do one of these devices. You need ECMO, which is why I think that insight is very important to understanding. This is one of the few, it's not even meta-analysis, but sort of case series comparing the different modalities in RV shock and acute PE. You see, VA ECMO has the most experience, but it looks like it has the worst survival compared to these other modalities. And I really think this is, as a retrospective analysis, we cannot separate out retrospective biases that were present. But if you think about it, none of these patients would have been an extremist that needed a therapy right that second. All of those patients who would have needed therapy immediately and emergently would have gotten VA ECMO. So of course, we've enriched this VA ECMO group for patients that are more sick. This was a series that I compiled, and we looked at PE and high rates of arrest. This should have a mortality of greater than 90%. But yet, with the application of ECMO in these situations, it was actually reasonably high survivals, much more than we expected. Again, this is just a collation of retrospective data, not a very robust thing, and certainly prospective and more rigorous studies are needed. We can look a little bit in bigger data sets to assess that. So the national inpatient sample in 2016 to 2018 looked at 3,000 high-risk PE patients, and the application of ECMO with therapy reduced the mortality rate by 39%, and even an arrest reduced it by 29%. The ELSA organization had 3 studies based on their database, so slightly different inclusion criteria, which accounts for the slightly different N. And one of the main findings from one of these trials was that the application of VA ECMO to PE-related arrest actually had a much higher survival rate compared to the application of ECMO for other similar lethal pathologies. But of course, again, you have to pay for that potential benefit and watch the rate of complications. So how would I think about acute PE? Well, I want to think right up front, just like we have that metric, that organizational principle. What is the patient's trajectory? What are the indicia? And I'm just thinking right up front, is this patient one who will need support? If so, then I would probably be thinking about ECMO. And that's really the state of that. And our final topic will be mixed shock. So by mixed, we mean multimodality, both insults to SVR and to cardiac output. This can be manifested in several different ways. So we could have one insult, like an arrest or post-bypass run, that leads to both distributive and cardiogenic pathologies. We could have a patient who presents with a vasodilatory shock and then later develops cardiogenic decompensation. This is called vasodilatory cardiogenic shock. Or we could have one of our primary cardiogenic shock modes. That patient later develops SIRS or an infection and has cardiogenic plus a vasodilatory component on top of that. This is common. So this is from the National Registry of CICUs, SIRS present in 1/3 of our patients. So it's certainly not rare. And the concept of sepsis-induced myopathy dates back 40 years. So looking at the EF decline in patients with sepsis. Now, actually, even in the initial reports, it was shown that the reduction in EF paradoxically was associated with increased survival. But it's actually not that paradoxical. If you have an LV that is responding to a vasodilatory state, it really needs to increase its stroke volume markedly. The ventricle that can dilate and do that will operate at a lower EF, but the one that can dilate is the one that can really augment its stroke volume to meet and combat that vasoplegic state. If you have a ventricle that maybe is stiff, thick, or small and can't do that, it'll maintain its EF, but it'll have an overall worse outcome. So if we think about, well, how would we think about mechanical options in these mixed shock states, we have to recognize one, these patients have two aberrancies. So they actually, in multiple data sets, have worse outcomes and multiple derangements in scoring systems, as well as laboratory and other markers consistent with shock. Additionally, these patients may be receiving crystalloid resuscitation for their vasoplegic state, which may contradict with the goals we have for the cardiogenic shock state. So if we do this thought exercise, when could we use mechanical support in mixed shock state? So, and maybe if we need concurrent respiratory support, that's certainly an advantage of ECMO. Maybe to reduce catecholamines, but the red column is a little bigger. Again, I come to this theme that ECMO is not resting the LV. If we're using this to support an LV that's sick and dysfunctional, that's not helpful. But the main argument against this that I find persuasive is that in a mixed shock or septic shock state, we have a syndrome that at the microvascular and vessel level is about malperfusion, cellular dysoxia, capillary leak. ECMO does nothing to treat those. In fact, it may worsen them because ECMO itself is an inflammatory stimulus. It also is a nidus for infection. It also can cause some of the other issues like bleeding and coagulopathy. And we heard yesterday, I think Dr. North's talk, that there can be impacts on pharmacokinetics. So we're trying to treat sepsis, and then we're putting on ECMO, which can change the volume distribution and binding. So it's fraught with difficulty. That being said, there are small data sets and one meta-analysis emerged. So these are in patients who were septic and on VA ECMO. And interestingly, you'll note this is really the part to look at. Overall survival 1 and 3, about the same if the EF was sort of moderately impaired, but much better if the EF survival was severely impaired. Again, these will all be plagued by biases that we don't know what the clinical team was seeing and doing at the time. Maybe this is a manifestation of the LV that can dilate was going to recover anyway. So this is really an area of investigation. And we at this hospital very, very rarely will use a mechanical support for mixed or septic shock. And this is sort of a survey of the literature that there's really a lack of consensus in defining this state, but also in using MCS for these states. There is one enrolling trial that I found. It's only enrolling 60 patients, but we may get some data about ECMO as a rescue therapy in septic-induced cardiomyopathy. So I'm just going to conclude with a few slides on the evolution of care in cardiology or critical care, which is obviously using information and knowledge gained from your history in pulmonary and critical care. This was a seminal study that was published from the Samsung Medical Center. I actually got to visit there last week. And what they did is they increased the intensity of their staffing, where a cardiac intensivist was really responsible for all aspects of the care versus a cardiologist in blue who was just sort of rounding. And they showed sustained decreases in mortality with a hazard ratio of about half. What's really interesting is that the cardiac specialist reduced non-cardiac modes of morbidity and death. So that's super important. And this concept has taken root in America. We at MGH have a fellowship program designed for this, where we try to teach critical care from a holistic point of view, from a cardiology foundation, but really trying to work and have that fellow study in the MICU, cardiac SICU, as well as the CICU. Why do I bring this up here? We have a 24/7 shock team of an in-house attending. So all of these decisions that I went through in the prior slides about thinking about who needs it, what device should you do? We have actually implemented and operationalized that by having an in-house attending sort of with this training heritage to help make those decisions. And data is emerging. So this is from, again, that same national registry. Having a cardiogenic shock team used more invasive hemodynamics, used more advanced MCS, and there was a trend towards improved survival. So lots to do in this field, but what I wanted to give you from a cardiac perspective to a pulmonary perspective, I wanted you to have a toolkit or heuristic of thinking about what is cardiogenic shock, what are the contemporary options, why might you use one option for one patient and not the other, recognizing that there's limited data in certain subsets like mixed and septic shock. And then again, the other theme would be, if you want to implement this in your hospital, very important to have a well-defined team, build protocols, including transfer protocols and quality protocols, things like that. So thanks, Dr. Frank. Thanks, everybody.